So it's a thrill to be back here, and thank you, Nina, for inviting me. Yes, this is my student ID that I managed to resurface from when I left Yale in June of 1998. So it feels very familiar and unfamiliar at the same time to be back, and in a good way. I got to meet with the MD PhD students this morning as well. So I have no financial relationships related to this discussion today. And I just wanted to start by putting things into perspective a little bit. So we are rapidly approaching the time where the prevalence of childhood cancer survivors is somewhere around 1 in 250 adults. And that really brings it home how crucial this issue of long-term toxicity and survivorship really is, because survivorship has some cost to it. So that we are now seeing more and more toxicity from therapy with longer survival. And we know that neurologic issues specifically can develop both as a consequence of the original cancer or brain tumor, as a consequence of the treatment itself, and as a late effect of treatment, and significantly influences both the quality and quantity of life. The late effects are most prevalent in CNS tumor survivors, and CNS tumors are second only to leukemia in terms of overall frequency. We also know that when kids survive, 95% of them have a chronic health problem by the age of 45, and 80% of childhood cancer survivors have a severe or life-threatening late effect. So the goals of my talk today are to review the most frequent reasons for neurologic consultation. In many ways, I consider myself an onconeurologist, just as you would have an epileptologist or a behavioral neurologist. I do neurology, but it's only focused on things related to childhood cancer and brain tumors. And then to recognize the neurologic complications related to treatment, including surgery, chemotherapy, radiation, and transplant, and then understand the basis for follow-up prevention and areas for intervention, which is really the new frontier now that we've spent many years cataloging what those long-term toxicities are, is that we're actually moving into a time period where we have some tools for intervention. So here's a list of some of the major issues that I see as a child neurologist who sees kids with cancer. And I'm going to talk about really the most frequent things that I see, beginning with headaches. So headaches are common in the pediatric population. If you were a pediatrician in the community, you'd see kids with headaches all the time. And I think the difficulty is when to get worried, especially if it's in the context of a kid who has known cancer. So I like to think about that in terms of if it's a child who has a change in the prior headache pattern, or headaches that were previously responsive to intervention that no longer are, any headaches that are associated with focal neurologic signs or symptoms, or associated with a change in cognition or behavior, those that are worse with bending, sneezing, or Valsalva, because those increase your intracranial pressure. Not all children walk in holding their hand to the top of their head in a classic vertex position. They're often much more subtle in terms of their presentation. And it's the photo here is just to remind us about the importance of the eye examination and looking for signs of increased intracranial pressure, which is obviously an emergency, looking for signs of papilledema. We know that there's increased risk of headaches when children have increased pressure, have a known brain tumor, or a prior history of hydrocephalus, or even those that have had a prior history of headaches. And then I think it's important to realize that we are often, as providers, the cause of their headaches, and not just in an emotional sense. Many of the therapeutic agents that we give, both in terms of cancer therapeutics and in supportive therapies, also can be an important cause of neurologic signs and symptoms. So specifically, things that we give like intrathecal chemotherapy and not just a post-LP headache, things related to acute and long-term effects of radiation therapy, second tumor formation and vascular changes. The supportive therapy and anti-nausea regimens that we use can not only impact symptoms, can disrupt sleep. I often get stories of families where their children are on ondansetron, and that really disrupts your sleep-wake cycles. And often what happens when a child has been diagnosed with cancer is that they're now sleeping in the family bed. And because they're cycling through sleep at much shorter time periods, they're noticing all sorts of sleep-related myoclonus and other things that are occurring that they've never either noticed before because they weren't in the family bed, or never noticed to this extent. Surgery, we know, can be a source of headaches, both because of the acute impact, hemorrhage or vascular injury, or even cerebrospinal fluid. And then, of course, this is a leveraged population that may be immune compromised. So you also need to think about whether or not there's possibility of an infection, fevers, or other vascular events. And this is a young child who had a developmental venous anomaly and had a venous infarct post-operatively related to decreased flow. So now I'm going to shift to hydrocephalus. As all of you may remember, our balance of cerebrospinal fluid is really related to the relationship between the production and the reabsorption of cerebrospinal fluid, and we know that fluid flows along predictable pathways. Signs of increased intracranial pressure in children can be a little bit more subtle. They may not be able to vocalize the specific symptoms. They may present with lowered cognition, memory difficulties, increased somnolence, and in young babies may actually have a bulging fontanelle. So that fontanelle is going to be open in a young infant. They may develop increasing head circumference and even have something called sundowning or sunset eyes, where all you can see is the white part of the conjunctiva. This is an example that I like to give not only because it's my patient, but it was actually my neighbor, who was a nurse at Children's, who came to me and said, you know, I measured my daughter's head because it seemed like it was bigger, and over the weekend it grew by 1.5 centimeters. She was a little baby. And this was in fact her head circumference curve, and it had jumped quite a bit in terms of her overall head circumference. And she ended up having what's called a choroid plexus papilloma, which is a tumor that produces cerebrospinal fluid. Because she had a fontanelle, that really was a little bit of a pop valve for her in terms of absorbing this amount of increased pressure. And it wasn't until she was no longer able to really accommodate for that amount of pressure that her head circumference was increasing, and she eventually developed a left-sided hemiparesis. But it actually took quite some time given the size of this tumor. Neoplastic meningitis refers to the situation where you have either increased cells or increased protein within the cerebrospinal fluid that gums up the system for reabsorption. And we see this with certain types of brain tumors. This is an example of a young child who had, you can see along the cerebellar folia, some increased signal intensity, as well as in the cisterns here. And now lower down in the spinal cord, there's a reversal of signal in the where you have the fluid that's brighter than the spinal cord. There's also some nodularity down in the thecal sac. Neoplastic meningitis can also be associated with leukemia and other liquid tumors as well. And signs and symptoms may be related either to signs of increased intracranial pressure because of decreased absorption, or focal neurologic abnormalities if it's also associated with some nodularity. And it's thought that tumors that are contiguous with the cerebrospinal fluid, such as those that are within the posterior fossa, we would see a typical pterygoid rhabdoid tumor, medulloblastoma, ependymoma might be more likely to actually send drop metastases, whereas the spread in something like leukemia is more hematogenous spread. In terms of seizures, I think it's important because seizures can be found in children with brain tumors and with other solid tumors. We know that brain tumors are found in 1 to 3% of children with the new onset of seizures, but up to 25% of children with a brain tumor may present with seizures. And in children with solid tumors or leukemia, these seizures may occur without any clinical or radiologic signs of any structural abnormality. It's also important to recognize that seizures can occur at any point from diagnosis to treatment to the time period of long-term follow-up or as a late effect, and there's some suggestion that the incidence is increasing with age. So there are some risk factors for seizures. So tumors that lie in the glioneuronal or low-grade glioma category are more likely to cause seizures, and this may be also because they're associated with areas of focal dysplasia around them, and also it's thought to be related to scar formation or altered levels of neurotransmitters. And there's a risk for seizure recurrence if there's been an incomplete resection or a lesion in eloquent cortex, which may go hand in hand as well, and also with dual pathology. Obviously, any child who's had a surgical resection for a brain tumor is at some risk because of the presence of scar in the prior surgical manipulation. And then we also have to keep in mind children who are treated with radiation who develop edema either from the tumor itself or acute edema related to the radiation may be at more acute risk for seizures. I think the difficulty that comes up in the pediatric population is it really a seizure? And this comes up all the time, and certainly none of us are very cavalier with the decision to start anticonvulsants, and that has some secondary consequences, as I'll get to. But kids do a lot of funny movements. Any of you who've spent some time around kids or have kids of your own know that sleeping babies do a lot of different movements. And as I mentioned, a lot of kids are now sleeping in the family bed and have altered sleep patterns and other types of movements that are happening, such as sleep myoclonus or REM motor activity. A lot of children have gastroesophageal reflux, which can trigger a vagal response, which in turn can also trigger a true seizure. I had a young child who had very dramatic breath-holding spells. He happened to be on vincristine and carboplatin and came in for weekly chemotherapy, and every time someone approached him with a needle, he had a breath-holding spell where he dropped his SATs to the 30s and turned blue, and the more people that came, the longer the spell lasted. So that can obviously present its own challenges when you have a child who's coming in for weekly treatment. And then a lot of these kids can be dehydrated. It's obviously true for adults as well, and have either fainting or syncope events. And I think the challenge is to know, is it truly a seizure? Is it an associated event? And when does it require an intervention? So in terms of the evaluation and the approach, I think obviously something that's a new seizure or change in the frequency or phenotype of seizures really raises the concern for tumor progression or tumor recurrence. And that's what parents are always worried about. And I would say often the concern for seizures is even greater in some respects than the tumor concerns. Our workup, we would consider neuroimaging or a lumbar puncture, depending on whether or not there's also concern for an infection, screening for metabolic derangements or potentially causative drugs. And then we use EEG a lot. And EEG can be helpful if the frequency of the events is such that you're able to record the events and know whether or not they're seizure versus non-seizure versus behavior. And again, this can be helpful in the terms of the decision to add an anticonvulsant, also in the decision to remove an anticonvulsant. And then if it's a brain tumor, also to consider whether or not they need further epilepsy-based monitoring, or is the patient a candidate for resective surgery. So in terms of the treatment considerations, it's important to know that children who are on adjuvant therapy have a 20 to 40% incidence of adverse events related to anticonvulsants. We know that anticonvulsants can worsen the side effects of concurrent chemotherapy and often act through the cytochrome P450 system, and therefore can decrease the effectiveness of the chemotherapy, requiring a higher dose of either the anti-neoplastic drugs and or a higher dose of the anticonvulsants. We tend to steer away from enzyme-inducing anticonvulsants and steer towards drugs that we know that are non-enzyme inducing. But anticonvulsants can also interact with corticosteroids and other components of our supportive therapy. And we know that anticonvulsants and chemotherapeutic agents can displace one another. In terms of the use of anticonvulsants as a prophylactic, this is an area that's much more controversial, and this was the topic of a controversies in neurology session at the American Academy of Neurology last year. And the definitive studies are lacking. It does appear that anticonvulsant prophylaxis reduces the frequency of recurrent seizures. However, the frequency of side effects, as I mentioned, is much greater. There are 4 randomized controlled trials and 3 meta-analyses, all of which were done in adults and none of which were very well designed or controlled, that suggest that prophylaxis is not beneficial beyond the 7-day postoperative period for a brain tumor. And the take-home message is really that we would consider prophylactic use of anticonvulsants in high-risk situations with metastatic disease, and when possible, we would choose a single non-enzyme-inducing anticonvulsant. And I'm going to walk through the neurological and neurocognitive effects of specific treatments. This was one of our original intraoperative MRI scans, and this is actually the finger of the surgeon during the time of the operating room. The neurosurgical late effects we know can really depend on a number of factors, including the location of the tumor itself. It always comes down to real estate, and that's going to determine whether or not the tumor is completely resectable or not. And particularly in the pediatric population, as it is in adults, the extent of resectability relates directly to the extent of curability. We know that toxicity is related to not only the experience of the surgeon itself, the attempted degree of resection, as well as the age of the patient and the pre-surgical performance status. We're lucky enough to have an intraoperative MRI suite at Boston Children's where after the initial tumor resection, the patient is actually rolled directly into the MRI. They're assessed to see whether or not there's residual tumor. They pop back out, and they can continue operating until there is no residual tumor. And for certain tumor types where extent of resection, as I said, is directly related to curability, that saves the patient from having to be closed up, go to the floor, get a scan, and come back down on a separate occasion in separate anesthesia. There are obviously some situations where super aggressive tumor resection is a little bit more controversial, such as the setting of craniopharyngioma, where now I think the field has gone in waves a little bit from attempting gross total resection and resulting in panhypopituitarism and potential vascular injury to backing off a little bit and using radiation as more of an adjuvant approach. And now the field seems to be swinging back again. And so I think it's the field is a little bit unclear sometimes as to what the cost is for aggressive gross total resection and what success you'll achieve as a result. We know that neurosurgery can cause some immediate effects, both related to neurologic and neurosensory deficits, endocrine dysfunction depending on the location, and neuropsychological deficits. And we know that children who are treated with surgery only are still at risk for many of the neurocognitive side effects. So when you compare those kids to kids in the general population, that's a much greater risk for neurocognitive deficits in children who require school-based services. There's a population of patients who are at risk for posterior fossa syndrome or something called cerebellar mutism, which is thought to develop within the first 24 to 48 hours of surgery, particularly those in the midline cerebellum, and are thought to be related to dentatothalamic tracts. And this can cause really a spectrum of abnormalities from mild to moderate to severe, which causes ataxia and sometimes a complete mutism, and now we're learning more and more about the language-based function of the cerebellum, and these effects can last for months to years, and often in association with significant emotional lability. In terms of chemotherapy-related neurologic effects, they're increasing in frequency as a result of our aggressive therapy and prolonged survival. And we know that these can be direct toxic effects or indirect, and the effects may be confused with metastatic disease. And I think one of the key things to recognize is that many of the new biological agents are now seen to have neurologic toxicity, but few have had long-term experience, and certainly none of that experience is in the pediatric population. And so it's really difficult to even know what to look for and under what circumstance. And I think it's also true that children are not just small adults, and so the way that they respond to some of these newer agents and in a developing brain may be very different from how adults respond to them. These are 3 such examples of some neurologic toxicity, including reversible, or I like to think not so reversible, posterior leukoencephalopathy. This is a child who had sinovenous thrombosis as a result of chemotherapy with asparaginase, and this is a patient who had clumping of the nerve roots related to multiple prior intrathecal chemotherapies. And you can imagine how difficult it would be to really detect whether or not there's any nodularity or tumor recurrence when it's supposed to be a free-flowing cauda equina and free-flowing nerve roots down there. It would be really difficult to know whether there's anything abnormal hiding beneath. In terms of overall chemotherapy side effects, hearing dysfunction is one of the more common things that we see, and it's worse when combined with radiation. We see later development of vision problems and cataracts. We see acute chemotherapy-induced peripheral neuropathy, or even central nerve damage related to intrathecal chemotherapy. We can see seizures forming, and I think there's a lot of controversy, as there is in the adult population, with the development of chemo brain in individuals treated with chemotherapy alone, and then long-term toxicity, including secondary cancers and leukemia. And when you look at the development of toxicity over time, it's important to remember that this doesn't happen at the time of treatment. These long-term effects can develop in the first year, in the second year, and multiple years after discontinuation of therapy, so children require ongoing screening for late effects. In terms of chemotherapy-induced peripheral neuropathy, this can be sensory, motor, or mixed, and the pattern is often related to the underlying drug. It ranges from paresthesias to severe disabling sensory ataxia. And I think it's often underappreciated in terms of frequency, and I can say that because I often see my oncology colleagues walking around with their stethoscopes to check their reflexes, and we know that that's probably not the best way to assess for peripheral neuropathy. Vincristine is a common agent used in the pediatric population, can cause a lot of gastroparesis and constipation, as well as jaw pain and knee pain. And the difficulty in young kids is that they may not be able to articulate that they're experiencing sensation changes or other changes, especially young kids with leukemia who are 2 and below. And this may be something more subtle that clinicians have to keep their eyes open for. My experience is that kids often more complain of pain, and I don't know whether or not that's because they don't have the language to say that they have other more specific symptoms, or they truly actually experience pain rather than true sensation difficulties. In terms of transplant, this is probably less well described. We know that the incidence varies from 10 to 40%, and that's eliminating patients that have had early mortality related to transplant. The biggest risk is in the first 90 days, and I think there are differing criteria for neurologic complications, which is also why it's probably underappreciated. It's generally thought that patients who receive allogeneic transplants from an unrelated or alternative donor have a greater risk. And in addition, that the post-transplant survival is lower in patients who have major neurologic complications. And so that really, I think, is changing a little bit how people are approaching screening for those types of complications, at least in the pediatric population in our institution. We know that there are other factors that increase risk, including history of total body irradiation, diagnosis of AML puts one at higher risk, and a history of prolonged immune suppression. And you can see that this population of patients with neurologic complications related to transplant had a significantly worse overall survival. In terms of radiation-induced neurologic toxicity, age is a really important factor. So we're talking about the developing brain here. And so the time at which a child is irradiated has a big impact on their long-term toxicity. And now that kids are living longer and longer, we're seeing an increased risk of secondary tumors, vascular abnormalities, endocrine dysfunction because of radiation to the hypothalamic pituitary region. We know that this is also related to the total dose and the region of radiation, as well as use of chemosensitization. And I'm just going to give you one such example because this was a landmark study done by Roger Packer, Children's National Medical Center, and this really shifted the way we think about the use of radiation in young children. So basically what they did was they looked at the age at irradiation versus the change in overall IQ, and arguably IQ doesn't really reflect all and everything about cognitive function, but you can see that children below the age of 7 were, in a relative sense, the most significantly impacted with a change in overall IQ of somewhere between 20 and 40 points, whereas children above the age of 7 were more spared from the effects in terms of effect on cognition. Tom Merchant at St. Jude's took that a little bit further and created a model where if you looked at time at radiation, for example, in a 5-year-old, which is the red line, over time, there was a significant impact on overall IQ, and that extended out beyond the time period after completion of therapy, such that 5 years later there was a 10-point drop. If you looked at kids who were 12 years old, by contrast, they were relatively spared from the impact on IQ. So obviously this isn't a perfect model, but I think it really takes home the point that age is pretty crucial, and if you can avoid irradiating a young child, then that's something you would want to do. We know that secondary neoplasms do occur after treatment for a brain tumor, and now that our population of patients is being followed decades after their initial treatment, the frequency is much greater, both in terms of overall second tumors. Those are more likely skin-based tumors are most frequent, and then leukemias, secondary leukemias, and secondary brain tumors. In terms of the neurovascular related effects, this is a particular area of interest of mine. Stroke is increasingly recognized as a consequence of childhood cancer and can have a number of underlying etiologies. In particular, we know that post-radiation strokes are increased in frequency. This is several decades after the original diagnosis. It's much more common in children with brain tumors who are treated with radiation, followed by children with brain tumors without radiation, followed by leukemia with and without radiation. And you can see that the cumulative index actually continues to increase decades after completion of therapy. We did a study at Boston Children's looking at the susceptibility of patients with neurofibromatosis type 1. There was an epoch where these patients who we know have a tumor predisposition syndrome were treated with radiation because it was an effective therapy. And we know that patients with NF1 are at risk for moyamoya even without the presence of radiation, but when you added radiation, they were at a significantly increased risk, and that this is also dose dependent. And we see a myriad of different types of vascular abnormalities in this population. We also know that there's an important interaction with other host risk factors. So other risk factors can accelerate the adverse cerebrovascular outcomes because of treatment at a young age. We know that systemic chemotherapy can cause changes in high-density lipoprotein and insulin resistance, and we know that coincident NF1 is an independent risk factor. And so I always tell my families and the other providers, you correct correctable risk factors as aggressively as possible. So that would include cholesterol, hypertension, and increasing activities to decrease the obesity. And we had a lot of discussions yesterday about that in our survivorship conference. And I'm going to spend the last few minutes talking about current therapeutic strategies. This is more at a national level where we're thinking about areas of intervention, and that can include prevention and/or early detection of late effects and changes in our surgery, chemotherapy, and radiation techniques. So in terms of improving outcomes for neurosurgical approaches, I mentioned the image-guided surgery and intraoperative MRI, this is an example of the system that we use where the patient actually goes straight into the MRI system right in the OR. Using image-guided surgery has really dramatically improved the safety and ease of tumor removal and probably the extent of overall resection. This was actually a card given to me by a patient. Roses are red, violets are blue. I lost my hair thanks to you. Talk about feeling a little guilty. So what are we doing about the radiation toxicity? Because we talked a lot about the long-term consequences. I think we try to avoid radiation in young children as much as possible. We try and reduce the dose of radiation, and many of our national trials are trying to push the envelope a little bit, sometimes successfully, sometimes, as we've heard at our most recent meetings, not so successfully, and therefore allowing tumor recurrence at a faster rate. But I think we're trying to be aggressive in those types of approaches. And then there are new focal radiation techniques to try and reduce the exposure of the radiation to the surrounding techniques and other organ systems. In terms of chemotherapy-induced peripheral neuropathy, there are several rather inconclusive studies, both in adults and pediatrics, that have looked at agents that are supposed to stabilize neuronal membranes or help in preventing certain elements of neurotoxicity. There was a study through the Children's Oncology Group that looked at sodium thiosulfate to prevent ototoxicity. It turns out that it's actually quite effective at preventing the ototoxicity, but in some subsets of patients may also be tumor protective. So I think the goal is to be able to give some of these agents at the time of treatment while at the same time not making the agents tumor protective. In terms of the big emphasis and part of the focus of our big survivorship conference yesterday is really thinking about late effect screening based on underlying risk and based on underlying exposure. And often that's done through a multidisciplinary team. We also really push towards increasing health education for our patients. They may have been treated at a time where they were too young to know what types of treatments they got. And so the goal is to provide a treatment summary and treatment exposure and follow up based on their risk, and also to treat those problems before they become severe. We're lucky enough to have all these folks to the right in one clinic at one time, so the patient will come sit in a room and we rotate through as part of their rotating dance card, so they'll see the whole team on one day and get their tumor scan. So we have the advantage to do that, as well as having a school-based team that not only attends their neuropsychological feedback sessions, but also goes to the school with our families to help negotiate for educational and vocational services. There are also throughout the country other hospital-based treatment programs and cognitive rehabilitation programs that are emerging as well. There are also some movement towards cognitive remediation and rehabilitation. So can you exercise the brain to get it to function better? So some of these are programs called Pay Attention and CogMed and Attention Process Training. I think the difficulty with these is that even though there may be temporary improvements, the durability of response, if you're not doing it on a continued basis, is much less secure. And lastly, we're really moving into an era both in terms of remediation of cognitive deficits and hopefully towards giving agents that protect young children from hippocampal damage and neurocognitive damage during the time of radiation. So a couple such examples are trials using methylphenidate and donepezil, and then a trial that's completing next month through the Children's Oncology Group, for which I'm the study chair, using modafinil over a 6-week period to try and improve attention, memory, and processing speed. So we really have taken things from a time where we're just beginning to catalog what those deficits are to now try and remediate those deficits, and now hopefully to push the envelope back a little bit further to try and prevent some of those deficits from occurring at the outset. So I hope in this brief tour that I've convinced you that neurologic complications not only can be the initial sign, but they may also be a sign of recurrence or a side effect of treatment many years after completion of therapy. And now that we have an increasing number of adult survivors, we have a population in major need of not only psychological and psychiatric support, but ongoing screening for some of these late effects. And the quality of survivorship really is impacting a lot with the developmental challenges of adolescence and early adulthoods. We know that with newer treatments and longer survival, there's also a greater impact of these neurologic deficits, which really emphasizes the need for intervention and follow-up over the lifespan and for our ongoing multidisciplinary survivorship programs. So I think I will leave it at that and open to any questions.